and in patients with pre-warming. So I'm not sure if you can see, but for patients with pre-warming 1 hour before induction of anesthesia, the patients will maintain their core body temperatures within normal as compared to those that do not have it. So hyperthermia, on the other hand, necessitates further investigation of its cause. If the increase in core body temperature is due to an infectious cause, then therapeutic management should be done. Antipyretics and antibiotics should be given. In the intraoperative period, fever is usually rare, no, because the expression of fever is depressed by the general anesthetic. But if any case that we do have hyperthermia in the OR that is not due to malignant hyperthermia, then the following maneuvers can be done. So we should always start with passive maneuvers first before going into the invasive maneuvers. Post-operatively, all of this can still be continued in the recovery room, as well as active removal of layers and exposure of the body skin to the environment. So during the post-operative recovery period, the body's thermal heat transfer situation is significantly different from when in the OR. So after they come from the OR to the recovery room, the anesthetic-induced peripheral vasodilation dissipates and thermoregulatory vasoconstriction begins. So why am I talking about this? Is because in the recovery room, when our patients are significantly vasoconstricted, applied skin warming is already ineffective. So if you did not institute warming techniques in the operating room, starting warming techniques in the recovery room will not be very effective for your patients. Okay, this is due to maximal vasoconstriction already. Also, this is another phenomenon that is seen in the recovery room. It is called the after-drop phenomenon, where there is a core temperature, a continual decrease in core temperature, and it is reflected. This is usually seen in cases of regional anesthesia. So this is caused by the delay in thermoregulation after your neuraxial technique or your peripheral nerve block. And this occurs when the extremities and the trunk are warmed simultaneously. So what happens is that there is a theoretic return of blood from the vasoconstricted extremities to the central core, and with it comes a drop in the pH and also a drop in core temperature. So active rewarming techniques can help here. So, in conclusion, here are the important points of my lecture. So temperature derangements happen often during any form of anesthesia, but what you don't see, you cannot manage. So careful monitoring, prevention, and treatment of thermoregulatory disturbances must be incorporated into a wholesome anesthetic plan. So it is recommended that temperature monitoring be done for procedures more than 30 minutes when significant blood loss or changes in temperature are anticipated and when active cooling or heating is to be done. Preoperative warming is a very effective and important maneuver for our patient. And the site and device depends on the surgery and accessibility and competency. So a combination of strategies should be used perioperatively to maintain normothermia. So I'm talking about pre-op, intra-op, and post-op. And post-operative hypothermia is difficult to manage, especially in the recovery room. So pre-operative thermal management is key. So these are my sources. Yeah, thank you.